Good morning, everyone. We start immediately our joint session between the Tunisian Society of Cardiology and the European Society of Hypertension. It's my pleasure to receive and welcome to Professor Thomas Weber from Austria, the president of ESH. And also I am honored to have many very good professors with me and my boss, Professor Boujneh, Professor Assia Bourzela, and my friend, Professor Salma Abslem. So without delay, I invite Professor Faten Triki to debate the first topic about diabetes and hypertension getting better balance, and we allow you to speak in French exceptionnally.
Merci beaucoup, Monsieur le Président. À mon tour, je vous remercie, vous et surtout tous les bureaux de la Société tunisienne de cardiologie. À leur tête, vous, Monsieur le Président Youssef Ben Amr, pour le succès, le grand succès de ce congrès dans sa 45e édition. Et nous sommes à la 3e journée et c'est des journées vraiment qui ont bien réussi. Là, je suis là pour vous parler un peu d'un sujet qui n'est pas du tout rare. C'est une situation assez fréquente, le diabète et l'hypertension artérielle. Comment faire pour mieux les gérer? Donc là, je n'ai pas de conflit d'intérêt par rapport à cette présentation. Donc je disais que ces deux pathologies ou ces deux facteurs de risque sont en fait un duo mortel. Un duo mortel pour plus qu'une raison. Déjà, on sait que l'hypertension artérielle, elle est beaucoup plus prévalente chez les diabétiques que dans la population normale, et que le diabète aussi, il a une prévalence plus importante chez les hypertendus, et les deux ensemble ne font qu'augmenter le risque cardiovasculaire, le risque de mortalité et d'événements cardiovasculaires majeurs, ainsi que le risque de néphropathie. Et les chiffres tunisiens, la prévalence de l'HTA qui est dans le monde, un chiffre de 30% d'hypertendus dans le monde. Nous, en Tunisie, on est pratiquement à 36% chez les hommes, 28% chez les femmes, ainsi que le diabète qui affole les 11 à 12% dans la population tunisienne. Un chiffre alarmant, encore plus quand on regarde nos hypertendus tunisiens dans notre registre Nature HTN, c'est des hypertendus qui sont pratiquement 40% de nos Tunisiens hypertendus sont diabétiques. C'est de gros chiffres. Et puis quand on regarde sur cette étude assez récente, c'est une étude qui est faite entre l'Afrique et le Moyen-Orient. Donc c'est quand même une population qui ressemble un peu à la nôtre. C'est vrai que la Tunisie ne figure pas, mais quand ils ont regardé plus que 3700 diabétiques sur 55 centres, ils ont remarqué que ces patients ont quand même 71% de ces diabétiques sont hypertendus. En plus, ce n'est pas des diabétiques à faible risque. Quand on regarde le risque cardiovasculaire de ces diabétiques-là, donc on est vraiment en bleu clair ou bleu foncé, c'est-à-dire un risque élevé à très élevé. Les diabétiques dans notre contexte africain et du Moyen-Orient sont des diabétiques à très haut risque cardiovasculaire. En plus, quand on regarde leur profil, qu'est-ce qu'ils font comme complication? La complication la plus fréquente chez cette population-là, c'est en fait la complication cardiovasculaire type coronaropathie. Ils sont plus que 80% coronariens dans cette cohorte d'études. Et cela fait que ces deux pathologies, finalement, ces deux facteurs de risque, ont en commun une physiopathologie commune. Ça tourne autour de l'insulinorésistance, qui est le premier événement dans le diabète de type 2 et qui en même temps va activer le système rénine-angiotensine, va stimuler le système nerveux central sympathique, il va donner cette dysfonction endothéliale de l'inflammation des éléments qui vont en fait agir en augmentant la résorption du liquide de sodium et en augmentant le liquide dans le corps et en faisant plus d'hypertension artérielle. Donc un mécanisme commun, mais aussi des facteurs de risque communs. On sait qu'un hypertendu, un diabétique, en plus de l'insulinorésistance, ont un codage génétique des deux, puis on a la dyslipidémie, et souvent sont des obèses. C'est des choses qui font que ces deux pathologies sont vraiment deux facettes d'une même maladie et qui va agir sur l'endothélium, qui vont plus donner d'athérosclérose, de fibrose et de l'inflammation vasculaire ainsi que du remodelage artériel. Tout ça va augmenter les complications micro- et macrovasculaires. Et d'ailleurs, on le sait, un diabétique tout court, déjà, il a un risque de faire de maladies cardiovasculaires, mais un diabétique, quand il est hypertendu, ça multiplie par 2, voire carrément par 3, le risque d'événements cardiovasculaires quand il s'agit d'insuffisance cardiaque. Et d'ailleurs, on parle d'insuffisance cardiaque, le fait d'être diabétique et hypertendu, déjà, on est à un stade A de l'insuffisance cardiaque. C'est des patients qui ont insuffisance cardiaque déjà au premier stade. Quand on regarde notre registre Nature HTN, nos insuffisants cardiaques sont plus que 40% des cas hypertendus et plus que 37% des cas sont des patients diabétiques. Maintenant, pour minimiser le risque cardiovasculaire de ces patients, on sait qu'en baissant la pression artérielle, et là la large étude EKPDS qui est ancienne, qui a très bien démontré qu'en baissant la pression artérielle des patients diabétiques, on améliore leur pronostic et on améliore les complications cardiovasculaires, le décès et l'AVC chez ces patients, d'ailleurs mieux qu'en baissant les chiffres de glycémie. Et ça, c'était à des chiffres de 144 dans le KPDS de pression artérielle systolique par rapport à 154 chez les patients qui étaient traités de façon conventionnelle. Après, vient Hotz qui avait un chiffre d'objectif de pression artérielle plus serré à 140 par rapport à 144. Et puis, à Advance BP, c'était à 134 versus 140. On a toujours un gain à gagner en baissant la pression artérielle chez les patients diabétiques hypertendus. Mais après, accord BP, elle s'est dit pourquoi on ne va pas baisser encore davantage l'objectif de pression artérielle chez ces patients diabétiques. Et ils sont partis à un objectif au moins de 120 mm de mercure par rapport à 140. Mais rappelez-vous que accord BP était pratiquement une étude négative. Il y avait que les AVC qui ont baissé. Le reste, c'était kiff-kiff. Avoir une pression artérielle inférieure à 120 ne fait pas mieux qu'avoir une pression artérielle inférieure à 140. Mais juste après, on s'est dit où aller vers le chiffre de pression artérielle, l'objectif de pression artérielle chez les diabétiques. Surtout, rappelez-vous, en 2017, on parlait trop de cette courbe en J, cette pression artérielle qui diminue trop, qui risque de faire plus d'événements coronariens, puisque les coronaires sont en fait vascularisés au moment de la diastole. Donc la question, c'est une question qu'après, avec Sprint, on a très bien démontré qu'en baissant la pression artérielle chez des patients de haut risque cardiovasculaire inférieur à 120, on faisait beaucoup mieux qu'en traitant de façon conventionnelle et garder l'objectif d'inférieur à 140. Cette large étude qui était positive sur tous les MACE, mais rappelez-vous, Sprint a exclu les diabétiques. Il n'y avait pas de diabétiques sur Sprint. Donc, il y a eu une étude de sous-groupe d'accord BP. Ils ont pris les patients qui ont le profil de Sprint, c'est-à-dire les patients à haut risque cardiovasculaire, âgés, atteintes néphropathiques associées. Et ils ont essayé de regarder dans ces sous-groupes-là, avoir un objectif inférieur à 120 par rapport à un objectif classique, conventionnel, et c'était une étude positive. Donc il y a eu quand même une amélioration des événements cardiovasculaires chez cette population de patients quand ils ont un objectif inférieur à 120. Et là, depuis, il y a eu d'autres études, comme celle d'une large étude chinoise, publiée en 2021, qui a démontré qu'en faisant un effort d'avoir une stratégie intensive de baisser trop la pression artérielle à inférieure à 120, chez une population du diabétique, on peut être efficace, mais là, ils ont l'avantage de faire des sous-groupes, et cet avantage, on le voit très bien chez les patients qui n'ont pas un équilibre glycémique sévère et chez les patients qui n'ont pas de troubles cognitifs. Donc, il conclut sur cette large étude qu'il faut aller trop loin dans l'objectif de pression artérielle chez les diabétiques, surtout quand ils ont un contrôle de diabète pas trop intensif et qui n'ont pas d'atteinte cognitive. Et de là, il y a une large méta-analyse qui a pris pratiquement 30 études, pratiquement 60 000 patients diabétiques qui étaient contrôlés par rapport à sa pression artérielle avec multiples cibles de pression artérielle, vous voyez, de 150 jusqu'à inférieur à 120. Et le résultat de cette méta-analyse, ça marche. Baisser la pression artérielle chez des patients diabétiques, ça marche même quand on baisse à une cible inférieure à 120. Mais là, il faut vraiment avoir des précautions. Ça marche très bien pour baisser le risque cardiovasculaire, pour baisser les événements cardiovasculaires chez des patients diabétiques. C'est pour cela que derrière ça, il y a une étude toute récente, la BP Road, qui a pris en fait des patients diabétiques à haut risque cardiovasculaire, pratiquement 13 000 patients qui ont essayé d'avoir un objectif serré, 121 de pression artérielle systolique par rapport à 133 dans le bras contrôle. Et ben, c'est une étude positive et une amélioration des événements cardiovasculaires chez cette population de diabétiques. De cela d'ailleurs, avec un petit prix à payer, qui sont les événements quand même indésirables, un peu plus d'hypotension orthostatique qui était symptomatique chez la population. On a baissé trop la pression artérielle, un peu plus d'hypercalémie dans ce groupe de patients traités de façon intensive. Là, il y a franchement une différence significative. De là, les recommandations ont été claires en 2024. L'ESC, elle parlait chez les diabétiques, il faut baisser la pression artérielle. La cible, c'est 120-129, donc c'est toléré. La même chose pour les Américains sur leurs recommandations de la CCAHA 2025. Ils parlent d'un objectif inférieur à 130 chez les diabétiques. Il faut encourager les inférieurs à 120, donc c'est toléré, et une diastolique inférieure à 80. Pour nos amis diabétologues, dans l'ADA 2025, ils sont aussi clairs. Il faut aller à un objectif inférieur à 120-80 chez les diabétiques. Par contre, les Chinois, dans leur publication toute récente de leurs recommandations de prise en charge de l'HTA chez les diabétiques, les Chinois le disent très bien, l'objectif c'est inférieur à 120-80, mais ils précisent que pour des populations un peu particulières, les très âgés au-delà de 80 ans, les patients qui sont coronariens, les patients qui ont une atteinte des organes cibles avec un dommage de leur organe cible, il faut être un peu plus modéré et garder le inférieur à 140-90 d'objectif. Par contre, comment traiter ces patients-là? Toutes les recommandations sont d'accord sur que le fait que ces patients-là doivent être traités par un bloqueur du système rénin-angiotensine, IUCORA2, en première intention en association avec un diurétique ou un inhibiteur calcique. Ils sont tous d'accord, que ce soit l'ESC, que ce soit la CAHA, ainsi que l'ADA. Et l'ADA 2025, peut-être ils sont un peu plus larges en matière de monothérapie. Ils vont vers la monothérapie jusqu'à la pression artérielle de 150 de systolique. Ils sont pour la monothérapie, qui peut être un bloqueur de système rénin-angiotensine tant que le patient a une albuminurie ou tant qu'il a une atteinte coronaire. Sinon, ça peut être un des autres drogues. Et la bithérapie, elle est préconisée dès que le patient a une pression artérielle au-delà de 150-90, et c'est toujours un bloqueur du système rénin-angiotensine associé à un inhibiteur calcique ou un diurétique en première intention. Les Chinois, ils précisent pour le diabète, pour l'équilibre du diabète chez un hypertendu, c'est plutôt recommandé de mettre un anti-SGLT2 ou un antagoniste des récepteurs de GLP-1 pour mieux faire sur le plan protection cardiovasculaire. Ici, le choix entre SGLT2 ou antagoniste de récepteurs de GLP-1, c'est surtout le profil de patient. Les obèses, on en préconise plus les bloqueurs de GLT, les antagonistes des récepteurs GLP-1. Et là, on revient sur les anti-SGLT2 qui sont de larges indications dans l'insuffisance cardiaque. Maintenant, on sait, avec leur mécanisme d'action rénale, sur leur mécanisme de baisse de la glycosurie, mais aussi de cet effet diurétique, sur leur effet sur la glycémie, mais surtout sur leur effet cardiaque, sur l'effet de remodelage, sur la baisse du remodelage cardiaque, leur effet au niveau vraiment hépatique. Tous ces atouts leur ont un traitement parfait pour le diabétique hypertendu qui risque d'être insuffisant cardiaque. On l'a dit, il est déjà au stade 1. Et d'ailleurs, ces drogues-là ont un effet sur la pression artérielle qui est modérée, mais qui est là. C'est un effet sur la pression artérielle et systolique et diastolique. Donc, ça va être une bonne option pour nos patients diabétiques. Il y a la phényrénone aussi, c'est un traitement qui est préconisé pour les diabétiques type 2, quand ils ont de l'HTA, mais surtout quand ils ont une atteinte rénale. Ça peut donner d'excellents résultats sur le plan protection des reins et protection cardiovasculaire. Et d'ailleurs, ils ont une place dans les recommandations. Ils peuvent être en classe 1 chez les patients ayant une néphropathie, une insuffisance rénale modérée à sévère avec albuminurie. La phényrénone, elle a une bonne place. Pour les anti-SGLT2, et pour les antagonistes des récepteurs GLP-1, ils sont d'indication classe 1 chez les diabétiques à haut risque cardiovasculaire. Et là, le choix entre les deux, c'est le profil de patient qu'il faut voir, surtout les obèses. Il faut privilégier les antagonistes des récepteurs GLP-1. La prise en charge du diabète ne s'arrête pas sur un pilier qui est important, qui est vraiment la baisse de la pression artérielle aller vers des objectifs très séduisants, inférieurs à 130-80, qui n'est pas toujours facile en pratique, mais il y a aussi l'action sur les lipides, l'action sur la glycémie, certes, mais aussi une prise en charge globale, des mesures hygiéno-diététiques globales de ce patient. C'est 4 piliers importants pour mieux prendre en charge notre patient. Et là, je reviens sur l'étude qui était faite dans un contexte qui ressemble de notre contexte africain, un contexte du Moyen-Orient. C'est des patients, quand on regarde ce qu'on faisait pour nos patients diabétiques par rapport aux recommandations, ils ont pris à l'époque les recommandations de 2021, et ben nous sommes qu'à 30% seulement de l'objectif de pression artérielle chez cette population de diabétiques dans notre contexte. Donc on est vraiment, ils sont sous-traités ces patients-là. Regardez, par rapport à l'hémoglobine glycée, on est pratiquement moins 40%, l'objectif de LDL cholestérol aussi à 30%, mais quand on regarde globalement tout ce qu'il faut faire pour un patient diabétique, baisse de la pression artérielle, mais aussi équilibre de diabète, baisse du poids, tout ça, on est pratiquement à 0%. On n'arrive pas à faire tout ça pour nos diabétiques, donc il y a beaucoup de travail à faire. Et là, je conclus pour dire que le diabète, c'est une pathologie souvent associée à l'HTA. C'est deux facettes, deux maladies qui atteignent le cœur et le vaisseau. Il ne faut pas être inerte par rapport à la prise en charge de ces patients-là. Il faut aller à des pressions artérielles très bien équilibrées pour pouvoir préserver le cœur et les reins de ces patients-là. Le patient reste au centre de sa prise en charge. N'oubliez pas qu'il ne faut pas traiter la maladie, il faut traiter un patient ayant ces maladies. Donc il faut avoir le patient au centre, beaucoup d'éducation thérapeutique et une prise en charge vraiment personnalisée de ces patients-là. Et je vous remercie pour votre attention.
Merci beaucoup, professeur Fettentrik, tu es toujours aussi brillante, aussi didactique, et je retiens de toute façon tout ce que tu dis. On va laisser la discussion à la fin, si tu veux bien, et j'ai mon plaisir d'introduire professeur Lilia Zahama, qui va nous parler d'une association encore aussi délétère peut-être que la première, et je veux parler de l'obésité et de l'hypertension artérielle, enjeux et stratégies de prise en charge. Lilia Zahama.
Thank you, Dr. Boujner. Good morning, everyone. Today, I will discuss the obese hypertensive patients. It's a true therapeutic balancing act, and this condition is increasingly common and clinically challenging. So, excess adiposity is a major risk factor for the development of hypertension. And obesity increases the prevalence of hypertension by a factor or 2 or 3 more in elder patients. And the global burden of obesity-related hypertension is rising worldwide, as you see here in the USA, but also in our African continent, contributing to increased cardiovascular morbidity and mortality. And understanding why obesity drives hypertension is essential to developing effective interventions. So pathophysiological pathways linking obesity to hypertension are very complex, and in adults, 20% of white fat is stored in the visceral tissue, and the expansion of visceral fat and its hallmark waist circumference is associated with increased cardiometabolic risk. So obesity impacts several systems simultaneously, and the neuroendocrine axis, inflammation, vascular and renal mechanisms, and these pathways are interdependent, and together they significantly increase blood pressure. We start with hormonal and neuroendocrine mechanisms. Leptin, with the satiety hormone, leptin levels are elevated to increase the adipose tissue, and however, we observe selective resistance to leptin's appetite-suppressing effects, while its ability to stimulate renal sympathetic nerve activity remains intact. And leptin acts via hypothalamic pathways, signaling to increase renal sympathetic nerve activity and hence blood pressure. Hyperinsulinemia adds an additional stimulatory effect on sympathetic nervous system and RAS, further sustaining hypertension. SNS and RAS, both systemic and local adipose RAS, are persistently activated, driving sodium retention, vasoconstriction, and increased cardiac output. The second mechanism is inflammatory and adipokine pathways. Dysfunctional adipose tissue becomes an active inflammatory organ and releases pro-inflammatory cytokines and decreases adiponectin. This imbalance drives oxidative stress, vascular inflammation, and increased peripheral vascular resistance. These inflammatory pathways are major contributors to obesity-related vascular dysfunction. From vascular perspective, endothelial dysfunction impairs vasodilation, increases arterial stiffness, and promotes vascular remodeling. And renal dysfunction, impairing sodium handling in the kidneys and glomerular hyperfiltration, which leads to volume expansion. An often underappreciated mechanism is the mechanical effect of excessive visceral and perirenal fat. This adipose tissue physically compresses the kidney, increases intrarenal pressures, leading to enhanced sodium reabsorption. Another mechanism yet is obstructive sleep apnea, which is highly prevalent in obesity and markedly increases sympathetic drive. And the interplay between these mechanisms create a self-reinforcing cycle where neurohormonal, metabolic, inflammatory factors perpetuate hypertension in the context of obesity. Gut microbiota and their metabolites represent novel mechanistic links between obesity and hypertension with potential for therapeutic intervention. So what are the implications of all these dysfunctional systems on the clinical management of hypertension? We can target these dysfunctional systems to counteract their effects. We know that in real-world cohorts, normal weight patients typically require fewer antihypertensive medications. As BMI increases, the number of drugs needed to reach target BP also rises, and this underscores the biological complexity of obesity-related hypertension. Regarding antihypertensive drugs, thiazides, ACE inhibitors, ARBs, and calcium channel blockers have comparable general efficacy. And however, thiazides are superior for the prevention of heart failure and somewhat better for stroke reduction. Despite their metabolic side effects, they do not worsen cardiovascular outcomes, and chlortalidone remains the most robust diuretic option. Conversely, beta blockers may promote weight gain and increase diabetes risk, and vasodilating beta blockers are more metabolically neutral and may be considered when needed. Renal denervation in resistant hypertension by reducing renal sympathetic activity can provide moderate blood pressure reduction of 2 or 3 millimeters. However, there is a considerable inter-individual variability of treatment efficacy, and robust predictors of response to renal denervation has not yet been identified. So whether renal denervation might have a crucial role in the treatment of obesity-related hypertension is still a matter of investigation. When obese patients have obstructive sleep apnea, treatment with CPAP improves moderately nighttime and daytime blood pressure by 2 or 3 millimeters. And it's by associating CPAP with weight loss that the reduction in systolic pressure can be far more greater, almost additive, the action with less than 8 millimeters of mercury. This isn't the case for diastolic pressure, unfortunately. So you see that we are not very effective in targeting these dysfunctional systems alone, and we need to focus on weight-centric management. So we start with lifestyle modification and weight loss, exercise, and dietary interventions, reduce leptin, increase adiponectin, and improve overall metabolic health, mediating blood pressure reduction. And the TRIUMPH trial showed that even in patients with resistant hypertension and a mean BMI of 36, structured lifestyle programs can significantly lower blood pressure by 13 millimeter of mercury for the SBP and 5-6 millimeter of mercury for DBP. However, long-term adherence to a lifestyle modification is poor and influenced by socioeconomic and cultural factors. Next is the pharmacological weight loss and the introduction of incretin receptor agonists has revolutionized obesity therapy, shifting from treating a single metabolic component to improving the entire metabolic milieu. GLP-1 stimulates insulin secretion, improves insulin sensitivity, promotes weight loss by suppressing the brain's appetite center, slowing emptying, gastric emptying, and increasing satiety. Liraglutide and semaglutide have been improved by FDA and EMA a decade now, and even oral semaglutide have shown a significantly reduction in body weight by 15% in the OASIS-1 study, and a reduction of 6 millimeter and 2 millimeter respectively in systolic and diastolic blood pressure. A recent meta-analysis with the GLP-1 receptor agonists on blood pressure in overweight and obese patients has confirmed this reduction in blood pressure for more than 37,000 patients. And this reduction is consistent across diabetic status, mode and administration, and treatment duration. More impressive is the demonstrated decrease of MACEs by 20% in overweight and obese patients in high cardiovascular risk, but without diabetes. More recently, tirzepatide is the first dual agonist that associated GLP-1 and another incretin receptor agonist, GIP. It offers even more potent weight reduction, improves blood pressure control with dose-dependent decrease in MACEs. Regarding SGLT2 inhibitors, they have demonstrated a modest impact on blood pressure reduction and weight loss, but to date, no RCT has assessed the net effect of SGLT2 inhibitors on BP as a primary outcome. Now we have metabolic bariatric surgery. It remains the most effective long-term treatment for severe obesity, and it demonstrated a reduction in systolic and diastolic blood pressure and the number of medication in obese patients. It outperforms non-surgical approaches for durable hypertension control and metabolic improvement, because while the short-term weight loss achieved by GLP-1 receptor agonists therapy is comparable to that achieved by bariatric surgery, its long-term effects are less consistent. On a population scale, visceral adiposity is a stronger predictor of cardiovascular risk than subcutaneous fat, and targeting visceral adiposity reduction may yield greater cardiovascular benefits. However, many patients face barriers such as stigma, socioeconomic limitations, and difficulties with long-term adherence, and integrated and patient-centered approaches are essential. So to conclude, obesity-related hypertension results from complex neurohormonal, inflammatory, vascular, and renal mechanisms. Key contributors include increased sympathetic nerve activity, selective leptin resistance, insulin resistance, RAS activation, and adipose tissue dysfunction, and emerging pathways such as the microbiome are expanding our understanding. And we have powerful tools available. We have lifestyle modifications. We have effective anti-obesity drugs, and we have bariatric surgery. And our challenge is to combine these effectively and ensure patients can access these treatments. Thank you.
Thank you very much, Professor Lakhama, for this bright and very comprehensive conference about obesity and hypertension, a very bad combination. Now we invite, we'll let the question for the end, but I cannot miss this opportunity to tell the Bureau of the Society of Cardiology how much I am impressed with the quality of this meeting, and I would like to congratulate them deeply. Now I would like to introduce Professor Fawzi Haddad, our bright conférencier, who is going to talk about protecting the kidneys, antihypertensive choices in chronic kidney disease. Please, Professor Haddad.
Thank you, Professor Bourzel. Good morning, everyone. First of all, I would like to thank the organizing committee for inviting me and for this kind of invitation and for the choice of this important topic about protecting the kidneys, antihypertensive choices in chronic kidney disease. As I said, is an important topic in our daily practice because the high prevalence of hypertension among people with CKD, around 67 to 92%. Also, CKD is an itself important risk factor for cardiovascular disease, and the coexistence of hypertension and CKD further increases the risk of cardiovascular disease event. Indeed, patients with CKD are 20 times more likely to die from cardiovascular disease than renal failure. So it's a cardiac problem before it's a renal problem. However, a majority of people with CKD have uncontrolled blood pressure, around 75%, so it's very important. But the first question, what is CKD? CKD, for most of us, is a decrease of GFR below 60 milliliters by minute. Indeed, there is a strong relationship between the decline of GFR and the increase of cardiovascular outcome or renal event. But CKD is also defined as the presence of markers of kidney damage, many markers, but the most important of them is albuminuria, represented by urine albumin-creatinine ratio more than 30 milligram by gram. And it's important to note that albuminuria is a strong independent risk predictor for end-stage renal disease, but also for cardiovascular disease, for death, all-cause mortality, cardiovascular mortality. But it's not only a marker of risk, it's a real factor of risk, because if albuminuria is reduced, cardiovascular endpoint is reduced. So it's very important to check this. But if you look at the Nature registry, Nature #10 registries, thank you, Professor Selma Abdeslam and Professor Leila Abid for this beautiful and for the largest national survey of hypertension in Africa. You can see that for patients, in Tunisian patients with hypertension, positive microalbuminuria was present in 30% of this population. However, unfortunately, only 15% had microalbuminuria test during the last year. So I can say easily that CKD is an underdiagnosis and under-recognized risk factor for cardiovascular disease in our practice. And if you want to complete the puzzle for a better certification in your patient, I think it's very important to check at least once a year the creatinine, the clearance, the GFR, and also the urine albuminuria creatinine ratio. So if you look at the last Tunisian CKD registry from the Tunisian Society of Nephrology, I think it's very important. You can see that there is a high prevalence of CKD in our Tunisian population, Tunisian hypertension patient, around 45.5%. So I think you have to pay more attention in this problem in our practice. So let's go to the treatment of hypertension in CKD. And the first question, what is the optimal blood pressure target for patients with CKD? It's an important question. Everyone knows the importance of the impact of SPRINT study, which changed our blood pressure target in patients with high cardiovascular risk with an intensive strategy. And in this sub-analysis in patients with CKD, you can see that intensive strategy showed an important reduction of the primary cardiovascular outcome with a significant reduction of all-cause death outcome. However, intensive strategy compared to standard strategy did not reduce the kidney outcome with an increase in acute kidney injury. So what we have learned by many trials in this field, that in CKD, blood pressure is lowered primarily to reduce cardiovascular risk, rather to slow CKD progression, with low evidence for slowing the CKD progression, except for patients with a high level of proteinuria. So how low should we go? What is the best blood pressure target in the different guidelines? Except for KDIGO guidelines, I think that USC, ESC, and ESH, and the last guidelines of the American Heart Association have the same simple message. It's very important to have a simple message, just to the systolic blood pressure less to be 130 millimeter of mercury in CKD patients. So I think it's a blood pressure is a good message. How to lower blood pressure in CKD? So the question, I think, is the same for the general population with some specificities. The first specificity is that the importance of lifestyle modification, especially for reducing sodium intake, less than 2 grams by day. There is no debate about the importance of this modification because, as you can see in this meta-analysis, we obtained an important blood pressure reduction of 7 millimeters of mercury with reduction of 36% of albuminuria, and it's the equivalent of one drug. So the lifestyle modification is very important in this population. With physical activity, we add physical activity also. What about pharmacological approach? Again, I think the same for the general population, but we distinct two groups. The first one is CKD stage 1 to 3, and the second group of advanced CKD with stage 4 and 5. You have to introduce or to start with single pill combination, RAS inhibitor, ACE inhibitor, or RBs, plus calcium channel blocker or diuretic. Diuretic for the first group and loop diuretic for the second group, but we will discuss this after. And why it's very important to introduce the RAS inhibitor, because you have large data like this US cohort clearly demonstrate that RAS inhibitor administration was associated with greater survival in all subgroup analysis. Also, we have many data confirm that we can slow the progression of CKD. We can reduce significantly the albuminuria, the proteinuria. However, when you initiate ACE or RB, it's very important to monitor creatinine and potassium within 2 or 4 weeks after starting. I recommend 2 weeks for patients with advanced CKD and 3 or 4 weeks for a patient with CKD stage 1 or 3. Three possibilities. First, to have, if you have normokalemia with less than 30% decrease in eGFR, at this time you can increase the dose of RAS inhibitor or to continue on maximal tolerated dose. If you have hyperkalemia, you can review concurrent drug. You can moderate dietary potassium and to consider sometime to add diuretic like loop diuretic or to introduce, we will discuss, the potassium binders. I think it's very important to have this medication in our country. Or if you have more than 30% decrease in eGFR, at this time it's important to review for cause of acute kidney injury, to correct hydration, to reassess concomitant medication, and sometimes to check if you have bilateral renal artery stenosis. So in these two conditions, you can reduce the dose or stop ACE inhibitor or RB, but it's important to remember that in STOP ACE trial, when you stop this medication, was not associated with a significant difference in long-term rate of decrease in eGFR, and we lost, I think, the benefit of cardioprotection for this. So I think it's better to maintain this strategy or to reduce the dose, but not to stop this medication. The other particularity of among this patient is the use of loop diuretic, but it's important to note that in a recent CLIC trial, try to evaluate the importance of clortalidone, a thiazide-like diuretic in patients with advanced CKD and poorly controlled hypertension. As you can see, you have an important blood pressure reduction, about around 11 millimeters of mercury, with a decrease of 52% of albuminuria. So it's an important impact. And we know that in Tunisia, we don't have clortalidone, we have hydrochlorothiazide. And in this recent study, compared clortalidone versus hydrochlorothiazide and kidney outcome in patients with hypertension, the same result in terms of blood pressure reduction, the same result about potassium level, and about kidney outcome. So we can use hydrochlorothiazide even in patients with CKD, with advanced CKD. What about resistance hypertension and CKD? I think it's very important because it's very common. More than 30%, despite triple therapy, we not target the blood pressure, the optimal blood pressure. And at this time, for the recommendation in the two groups, you can see that the importance of using spironolactone, it's preferred. And after you can use beta blocker, alpha blocker, and other strategy. But spironolactone is the reference treatment for resistance hypertension, but according to the Pathway 2 study, but in this study is an acute patient with eGFR more than 45 milliliters by minute. And you know that the problem is hyperkalemia. And if you used patiromer, it's a potassium binder, where I think it's very important to introduce these drugs in our country. As you can see in the UMBRELLA trial in patients with advanced CKD, persistent use of spironolactone is more than 84%, with an important reduction of blood pressure with few adverse events. Also, we can combine clortalidone and loop diuretic in this population with advanced CKD, according to the sub-study of CLIC trial, and you can see the combination, the blood pressure difference, it's very important, 40 millimeters of mercury, so it's important to combine loop diuretic and thiazide-like diuretic or thiazide diuretic. But I think the future will be with this drug. Baxdrostat, it's a new drug with an aldosterone synthase inhibitor. And as you can see in patients with uncontrolled and resistant hypertension, we obtain an important blood pressure reduction around, for the systolic or for the diastolic, around 40 millimeters of mercury. And we obtain the same benefit in patient regardless of eGFR more and less than 60 milliliters. Before I finish, just to remember that it's very important to add SGLT2 inhibitor in this population, in this high cardiovascular risk population, according to our last guidelines for the ESC. We recommend it's a recommendation class 1, level A, in hypertensive patients with CKD and eGFR more than 20 milliliters by minute. SGLT2 inhibitors are recommended to improve outcomes in the context despite the modest blood pressure lowering properties, because as you can see in the recent meta-analysis, the benefits of the kidney outcomes is very, very important, regardless of baseline eGFR, regardless of baseline urine albumin-creatinine ratio. We will improve the kidney outcomes in all these situations, and everyone knows the importance in cardioprotection for SGLT2 inhibitors in terms of reduction of cardiac death and hospitalization for heart failure. So my take-home messages is hypertension is highly prevalent in CKD, more than 80%. Lowering blood pressure primarily reduces cardiovascular risk in CKD. Use home blood pressure measurement of IBPM for diagnosis and follow-up, because masked hypertension is very frequent, around 27% in CKD patients. Target the systolic blood pressure less than 130 millimeters of mercury in most CKD patients. Don't stop RACE inhibitor in advanced CKD. Thiazide diuretic are efficient even if eGFR less than 30 milliliters by minute, and additive efficacy and combining diuretic in resistant hypertension in CKD is also effective. Thank you for your attention.
Thanks a lot. We've been used to Fawzi Haddad of the French version, and Fawzi Haddad in the English version was as bright, as accurate, as straight to the point. So thanks for this excellent presentation.
Thank you.
We have the best for the last topic with the president of the European Society of Hypertension, Professor Thomas Weber. He is a brilliant cardiologist, professor of cardiology, and past president of the Austrian Society of Cardiology, and will have a wise insight for the future of hypertension. What next, what to do next in hypertension after 2025. The stage is yours.
So, dear Chairman, dear colleagues, first of all, thank you very much for the very kind introduction. Then second, let me express my deep gratitude for inviting me to your very successful conference, and congratulations to this. And third, I have to apologize for giving my lecture in English language. So that's one of the few things in life I always, can speak French. So, very well. So let's start with the topic now. And the question is management of hypertension now and in the future. Are we there yet? And if yes. So first, let me just quickly tell you where I come from. I come from the country of Austria, which is a small country in the middle of Europe, just 2 or 3 hours with a flight actually from here. So what we do have, we have old palaces, new buildings, that's the United Nations building. We have picturesque villages at small lakes and within the mountains. And we have some composers you might know, that's Wolfgang Amadeus Mozart, for sure. And that's where I'm working. I work here actually in the middle of Austria. That's the old and the new building of my hospital. These are my conflicts of interest, and the most important conflicts for sure is my relationship with the European Society of Hypertension now for a couple of years. Okay, where do we stand, dear colleagues? And that's from a very hot off the press just a few weeks ago released the global report on hypertension from the WHO. And what you see here is in green the situation in my country, and in blue the situation in your country. And what you see here in shaded green and blue is the percentage of patients with controlled hypertension. And what you also see is in dark green and dark blue the percentage of patients with uncontrolled hypertension. And so my impression is there is a lot to do in both countries, actually. And this is even more important when you consider that high systolic blood pressure now is and will remain in the future, that's a projection of the next 25 years, the #1 population attributable risk factor for cardiovascular disease. And it's even worse, these are also new data from released in the New England Journal of Medicine. If you do have hypertension, this comes at the cost of 2 life years in Western European countries and even 3.7 life years here in North Africa and the Middle East. So indeed, there's a lot we need to do, and we need to have strategies how we can deal with that. So, okay, we always have very good recommendations, and a lot of them have been shown today. The guidelines, our last guidelines, ESH guidelines, 200 pages, 2,000 references, something which probably nobody in the world will read except the authors or some of the authors. So we distilled a clinical practice guidelines with 15 pages, and even this is a little bit long, so we distilled, or we made a plan, we made the so-called master plan for the management of hypertension, which is meant to be pragmatic and practical and used in everyday clinical practice. And of course, MASTER is an acronym. It's measure blood pressure, assess the patient, select therapy, and evaluate the response. And I will quickly go through with you for the rest of my topic now. So what about the measurement? That's what you have in the clinical practice guidelines. We do have, of course, these 3 methods by now. The cuffless methods are very interesting from a scientific point of view, but they are not yet there to be used in clinical routine. So, first of all, we do have the office blood pressure measurement, the old one, of course, and you see here the thresholds for the diagnosis of hypertension, at least in Europe, 140/90. Home blood pressure monitoring, of course, very important. The thresholds are slightly different, 135/85. And then you do have the ambulatory 24-hour blood pressure monitoring with the same thresholds for the daytime, lower thresholds for the nighttime, 120/70, which gives you then a lower threshold for 24-hour average blood pressure, 130/80. And, of course, your diagnosis and your assessment of the blood pressure status of a patient always has to be based on the average of several measurements. To start with office BP, you see the thresholds there. Kind of unfortunately, that's the only method which has been used in almost all of the outcome trials as the basis, which means that we still have to consider it, okay? We cannot abandon it, although we have discussed this in depth. So it's a basis, in a way, for the diagnosis and blood pressure targets. You have to do this in a very structured way, in a very standardized way, because blood pressure has a very large variability, meaning the fluctuations of blood pressure. And if you don't do it in a standardized way, you will never know what's the status of your patient. The problem is it's not done in clinical routine. It's not done in Europe. It's not done in Austria. I don't know about Tunisia. But it's hard to do in a way. It takes time. So first, that's easy. You have to take a validated automatic electronic upper arm cuff device. So no auscultatory anymore, but validated and upper arm. Important, you see one of the websites where you can find the devices. Appropriate cuff size is important to have the patient at least 3 to 5 minutes seated and no talking when you do the blood pressure measurement. Posture, etc., that's known, that's medical school, in a way. We should take 3 readings at 1 minute intervals, so one after the other actually, and use the average of the last 2. Home blood pressure monitoring, it's very popular in Europe, very popular in Austria. I hope it's very popular here in Tunisia as well. The conditions and the posture are the same, but we have to educate the patients because the patients can't know they are patients, they are not doctors. We should use a standardized protocol. The best is to have a measurement week in the week before the patient is seeing his GP again to write it up, and then you have the actual blood pressure status. The patient has to take 2 readings at a 1 minute interval. It's highly relevant for long-term follow-up of treated hypertensives, and indeed there are studies which show that it improves blood pressure control. Then we do have ambulatory 24-hour blood pressure monitoring. It's very interesting, a very nice method. I always use this in my hypertension clinic, but maybe I'm in a good situation to do this. So you can obtain a 24-hour blood pressure profile. For sure, in true resistant hypertension, it should be used to confirm the diagnosis of hypertension. And we should do it on a routine work day, not on a leisure day. Blood pressure may be very different if there's a stressful environment in the working situation. And now we recommend 20-minute intervals during daytime and during nighttime. So that's a little bit of a shift. So the indications, there are a lot of indications, but nobody has to know them, actually. It's written in the guidelines, but it's not important because what we do have in our guidelines, and that's the same for ESC, we do have a class 1 recommendation for out-of-office blood pressure monitoring anyway. So we should do this basically in each and every patient. So to very quickly summarize, office blood pressure in a way is the basis. Home should be done in most treated individuals in 24 hours. It's a unique diagnostic method, very interesting, gives you a lot of information. But there is a big but. You have to consider, when you look at all the thresholds I have shown you and also which have been shown in the previous lectures, the relationship between blood pressure and cardiovascular risk is not a step up or something like this, it's continuous. Actually, here is a log linear relationship, which means if you find different definitions for hypertension, that's okay, that's perfectly okay, and this is due to ongoing studies, etc., ongoing study results. So, assessment of the patient, this has not really changed over the last years, and that's just a summary slide you see in the practice guidelines. But what's important, assessment should be adapted according to the severity of hypertension and the clinical circumstances. So it's meant to be pragmatic. That's why we say we do have some assessments which are extremely important or necessary. Albuminuria, for instance, is very, very important to assess. And other assessments are feasible. If they're feasible, it's very nice. It's a nice to have. You should do an echo, that's a cardiology conference, I understand, I'm a cardiologist as well, but it's not mandatory, I would say, in all hypertensive patients. So it should be pragmatic, but it should be done. Personal history, of course, we do in anamnesis, we talk to the patient first, that's very simple and very clear, I think no need to spend too much time. We have to look at additional risk factors, and they have been mentioned in the previous lectures, diabetes, chronic kidney disease, etc., weight gain, of course. We should look for hypertension-mediated organ damage. It's a nice to have, but it's not mandatory in each and every patient. Of course, we should screen. We're internists, we're cardiologists. We should screen if there is secondary hypertension, if we have any clues, and then we should have an in-depth investigation, of course. But also, it's not mandatory for, say, uncomplicated hypertension, which is easy to control with 1 or 2 drugs. But for instance, if you have a young patient with the onset of severe hypertension, right, then of course we have to look if there is secondary hypertension, and I just highlighted one, which is hyperkalemia, which is then of course a clear indication of possible hyperaldo, which seems to be even more interesting in the future. Baxdrostat, etc., was mentioned already. We have to look at drug treatment or use of other than antihypertensive drugs, not only the non-steroidals, also anti-cancer drugs, etc. Physical examination in general in hypertension most often doesn't reveal many important results. I think the body mass index is one of the most important things to look at this here. What about then therapy? We heard that the percentage of controlled hypertension is well below 50%. In both countries, Tunisia, Austria, and I think globally. So it's more 30% or something like this. With the right treatment, and this is based, by the way, these 30% are based on the 140/90 threshold. It's not based on the new thresholds I will share with you in a minute. So then, what about the treatment? So you have a patient here with hypertension, grade 1, 2, 3. You have his or her cardiovascular risk, so from the green, the good situation, to the dark red, the high-risk patient. We need lifestyle interventions in all patients, that's for sure. In most of them, we have to immediately use antihypertensive drugs, and we aim for blood pressure control within 3 months. At least in the European Society of Hypertension, we still think that there should be some small room for lifestyle modification only, but only in patients with low cardiovascular risk, so the green ones on the very left side here, and if blood pressure is on the lower side of the grade 1 hypertension, but only for 3 months. If this does not work, you should not continue this for years. If the patient is able to, change his diet, etc., that's fine. If not, okay, we do need antihypertensive drugs. And that's how we stratify risk. I think you know this already. It's, of course, the cardiovascular risk depends on age, which is the #1 risk factor, the grade of hypertension and the staging. So stage 1 would be uncomplicated. All the other stage 2, already diabetes, CKD present, we have heard this dramatically increases cardiovascular risk. That's the lifestyle interventions we mentioned in the clinical practice guidelines. And if I go into detail a little bit, indeed, if the patient is successful, or we are successful together with the patients to start lifestyle interventions, this may prevent or delay the onset of hypertension, and also the booster, the blood pressure lowering effect of medications. It's incredible what you see in some of these patients, but they have to do it. It has to be done, and it's not easy, of course, we already heard it. And thus, it should be, lifestyle intervention should be prescribed to all patients with diagnosed hypertension and also to those with high normal blood pressure because they are at very high risk to develop hypertension in the future. A healthy diet, well, the Mediterranean type diet, okay, we are here, I understand in Tunisia, I don't need to speak about this. Salt restriction, of course, but also augmentation of potassium index, that's new in the guidelines due to a couple of very interesting studies, mainly coming from China. Physical activity, weight reduction, it has been mentioned. And then about what about antihypertensive drugs? That's again the overview slide we have in the clinical practice guidelines. And first of all, we need to know the blood pressure target. And this has really changed, and fortunately, it's consistent, at least in Europe and in the US. And the target for systolic blood pressure now is 120 to 130. For all patients up to all adult patients, I have to say, up to the age of 80, maybe 85. Here it depends on the level of frailty. It's more biological aging than chronological aging. So target 120 to 130 and diastolic 70 to 80. In the US, there's even some recommendation to go below 120. So please keep in mind, blood pressure control status in our populations is 30% at 140 over 90, which means it would be, 5% with the new target. So there seems to be a lot of work to be done. Which drug classes should be used? ACE or ARBs, diuretics, calcium channel blockers, and also beta blockers. We keep them, but I will explain to you. And then there are additional drug classes which have been mentioned already in a couple of lectures before. The most important thing now, and this is still not the reality in my country, we should start in almost every patient with high blood pressure with a dual combination therapy. Just do it, because it's not only for renal denervation that the response to antihypertensive actions, medications, it has a huge variability. This is also the same for antihypertensive drugs. So we need at least 2 antihypertensive drugs in all of the patients. We at ESH recommend to uptitrate to the max of well-tolerated doses and then to triple if needed. Once daily, of course, is preferred if we do have a single pill combination available, which is not the case in all countries, which I understand. So we can still start with monotherapy only in selected patients, the low-risk hypertension and the blood pressure in the lower range of grade 1 hypertension, or even high normal blood pressure and very high cardiovascular risk, which would be a patient with coronary artery disease or frail elderly patients. And that's the algorithm I've already shown to you, but here it's on a figure. So you start with ACE-ARB or a plus calcium channel blocker or diuretic. If this is not enough, you need all 3 of them. And then with this, we should be able to control blood pressure in 90% of the population, which is much, much, much more than we do have now. So with a very simplified approach, we hope this would work. You can use beta blockers at all stages if there is a special indication, or even better, if you have a guideline-directed medical therapy, which includes beta blockers like heart failure, coronary artery disease, etc., etc. Use of diuretics, it had been mentioned. Clothalidone has, in my opinion, a special role, and it works very well in patients with advanced CKD. And finally, we have to consider, which is also not really mentioned in the old guidelines, hypertension is not a disease, you make a diagnosis, you start to treat, and then it's gone. It will be a condition which goes with your patients for the rest of his life, probably, and with you as the doctor as well. So we have to think about, at least there are not many good studies on that, but we have to think about how we can move forward, or we have to move forward. So when you initiate drug treatment, of course you have to do 1-2 visits to look, okay, does it work? Verify initiation and discuss adherence, very important. So is the patient able to tolerate the treatment, etc. Then you have to do, of course, selected lab tests, and I think creatinine, potassium has been mentioned correctly already. If the patient has apparently treatment-resistant hypertension, an ABPM would be good. Maybe you have to refer the patient to a specialist. And so that happens in the 3 to 12 months. So lifestyle interventions, have they been installed? Have they been started? Do you have to adjust the medications? Are they tolerable? What about side effects? What about adherence, which is something not very easy to monitor? And after the first year, you have to consider, is this the low-risk patients? So probably 1 visit per year would be enough. All general practitioners are overwhelmed with work, at least in Europe. So, but if it's high risk or difficult to control blood pressure, for sure more frequent visits would be appropriate. And if you have assessed hypertension-mediated organ damage at baseline, it would be good to check at least if there's a change of albuminuria, atrial stiffness, whatever, left ventricular hypertrophy. So, again, thank you very much for inviting me here. So I invite all of you, if you're interested in hypertension, to the next ESH annual meeting, which will be held by the end of May next year in the nice city of Gdansk, which is in the northern part of Poland at the seaside. And I promise we do have a lot of innovations, not only basic stuff which I presented to you here because I think it's important, a lot of innovations which is ongoing with diagnostics, with treatment, etc. So if you're interested, I would be happy to welcome you there, and thank you very much for your attention.
Thank you very much. We have to close the session. All speakers, please, you stay in the podium for the photo. I would like to thank all the audience, the speakers. Faites une photo et vous restez sur place pour le symposium Servier.